Hello, everybody, and you're very welcome to tonight's webinar, which is in conversation with members of the Antimicrobial Stewardship Community of Practice for European Antibiotic Awareness Day. My name is Fiona Leonard. I'm one of the Pearse Board pharmacists, and I'm also a community pharmacist. So we'll start with just some quick domestics. This webinar is being recorded. All your microphones have been muted. You can leave your videos on or off as you wish, but if you are experiencing problems with connectivity, it's probably a good idea to turn your video off. If you have any difficulty with sound, ensure the speaker or sound is not muted or turned down on your computer or phone, or you could try logging off and logging back on again. Please use the chat function for questions or comments, and we may use some anonymized information from the webinar. And please, again, complete the post-webinar survey because it does help to inform what the IAOP does in the future. So now I am going to introduce tonight's panel to you. So we have tonight's webinar is going to be slightly different in that we have a panel of people who are very active in the antimicrobial stewardship community of practice, and they're going to give us a flavour of important antimicrobial stewardship work that is being undertaken at the moment. So we have Marie Philbin, Chief Pharmacist with AMRIC, Mala Shah, and Ellen Martin, so all HSE AMRIC pharmacists. Then we have Anne-Marie Garvin, antimicrobial pharmacist, Connolly Hospital, Blanchardstown. Dr. Scott Walkin, GP, AMRIC clinical lead of the ICGP, and Ailbhe, CPD, quality assurance pharmacist with the IAOP. So now I'm going to hand you over to Marie.
Thank you, Fiona, and good evening all. Thank you for joining us on this webinar this evening to share examples of ongoing antimicrobial stewardship work and to highlight the importance of that work. I will commence by sharing a video clip of a pharmacy student, coincidentally, Amy Symington, and her own patient story. Her powerful message clearly shows us the importance of antimicrobial stewardship to keep antibiotics working.
Amy Symington was always fit, healthy and sporty, but 18 months ago, pain in her hip left her unable to walk and led to a 4-week hospital stay fighting MRSA.
I just remember vividly in school learning about MRSA and our teacher describing it as this superbug, which was, one that's resistant to a lot of the antibiotics that they use to treat all sorts of infections. So I think that set in a whole other level of panic.
But treating it was difficult, as the bacteria causing the infection had developed resistance to many antibiotics. But after trying many different ones, doctors found a combination that worked.
I just think it's really important that we keep these types of medicines working, because I won't be the last one that's going to rely on them.
Thank you. I'm sure you'll agree antimicrobial resistance has had a significant impact on Amy's life, and we acknowledge her impact, her contribution to the fight against antimicrobial resistance by her sharing her story. It's really important we keep the patient central to all of our antimicrobial stewardship work. And antimicrobial stewardship work can be achieved at many different levels depending on your role. It's not just necessarily that patient safety, that patient facing role. So I think that's very important for all of you on the call or listening to the recording to bear in mind. We welcome all of our PAMSnet members tonight. And for those of you that are new to PAMSnet, I'll give a brief overview of our community of practice. Our mission statement is to support pharmacists across all sectors towards the common goal of promoting responsible use of antimicrobials in all patients to limit the emergence of antimicrobial resistance. We have a very active network. We are continuously growing. We have approximately 300 pharmacist members. We host educational events throughout the year. And through the Irish Institute of Pharmacy platform, we have a discussion forum, and also on that platform we share various updates and resources in relation to antimicrobial stewardship. We have a very active working group that help us guide and build and direct the direction of travel of the group, and we're very grateful to them for their work. One of the next slide, please. Can I move? Yeah, thank you. One of the bigger pieces of work that the group have undertaken recently is to prepare a submission, and that has been sent to the Department of Health that will hopefully inform Ireland's third National Action Plan on antimicrobial resistance. And three significant considerations that were taken in account of in the submission were that antimicrobial use in human health in Ireland is accounted for 90% in the community. The EU Council in 2023 recommended to Ireland that we reduce our overall consumption of antibiotics by 27%. So the third consideration is born around those two factors. So now we really need to significantly reduce our antimicrobial use. So we need to have a shift from thinking what potentially green or narrow spectrum antibiotic is prescribed for a patient to consider whether the patient needs an antimicrobial at all. And that will be a really key piece as we work through INAP 3. Next slide, please. And this submission was very much a collaborative viewpoint, and we're very grateful to all of our working group that provided significant input and thought around that submission. It really highlights the unique value and impact that pharmacists across all settings can bring to the fight against antimicrobial resistance. Pharmacists are ideally placed to be stewards of antimicrobials. The close connection that they have in delivering care is ideal to improve patient outcomes in this regard and reducing the risk of antimicrobial resistance. As highly trusted healthcare professionals, they have a vital role in educating the public on various issues to prevent antimicrobial resistance and improve the use of antibiotics. Next slide, please. And over the course of the next two slides, I'm just going to share with you some of the key areas that we focused on in this submission. And really, I suppose the overarching theme of it is to embed antimicrobial stewardship in pharmacy settings in pharmacy services in all settings. And a key part of that is around education and training of pharmacists, be it at the undergraduate level or for our registered pharmacists and supporting them in their continuing education and hopefully consideration of having mandatory education on antimicrobial stewardship, which has been successful in some other countries. Next slide, please. And in terms of supports of our practicing pharmacists, we hope to significantly grow the PAMSnet community of practice, and a really central part of doing that will be having a digital platform that is very accessible, facilitates engagement among the profession, and very user-friendly. Then we also focused on interventions that our pharmacists can do in various settings. I've included some examples here for community pharmacists around delayed prescriptions, participating in patient-facing media campaigns, engaging with prescribers, audit, etc. And in order to do this and to define what we really need in terms of interventions, it's important that we have accurate and comprehensive antimicrobial consumption reporting, and currently there's a significant deficit in this area. The final point I want to touch on that was included in this submission is around the role of the specialist antimicrobial pharmacist. And it's fantastic to see our antimicrobial pharmacist colleagues in the acute hospitals now working in the advanced specialist pharmacist grade. However, it's essential for the delivery of antimicrobial stewardship across the health service that these grades will be made available to colleagues working in the community settings and in various national roles. As we move to our panel discussion, it would be fantastic if you could participate in this poll and give us an indication of what your area of practice is. Thank you. Okay, are we getting any indication?
I'll just share the results now.
Great. Okay, so we certainly have a broad spread. We have community pharmacists, we've hospital pharmacists, we have our specialist pharmacists from hospital and community, and we have pharmacists working in academia and education, and we have a good cohort of students among us as well. So you're all really welcome, and it's great to see that we have such a broad spread. And again, that really is the aim of PALMSnet, to reach across the profession. We're going to, before we move any further now onto our agenda, we're going to pause. We're going to take down the slides to open up for panel discussion. And we want to, I suppose, consider our PALMSnet that we have just spoke on, that I've introduced you to, and explore that a little bit further with you. So, Ailbhe, if I could bring you into the discussion, and in your role in the Irish Institute of Pharmacy, I suppose, what value do you see as PALMSnet bringing to the pharmacy profession?
Thanks, Mary. I suppose we're very lucky in the Institute to work with pharmacists from across all sectors, and I think what we've seen across various projects is when pharmacists really come together to work and connect on projects, really great things can happen. So we've seen it. There's the peer support pharmacist network, we've a mentoring network, and now there's also the PALMSnet community of practice. So we do host the forum discussion page, and I think it's just been fantastic to see it go from strength to strength and really work as it was intended, which I know you've touched on. So really to share knowledge and experience, support pharmacists with their CPD, support pharmacists with their day-to-day practice. It's a great place to get information from across all sectors. I'm signed up to it. I see the emails coming through. I know you're constantly posting updates. Other members of the working group that, again, are from across all areas. So you've got hospital pharmacists, community pharmacists, pharmacists in academia. It's a really good place to get kind of access to quality assured information, highlighting items of interest, articles, case studies, surveys, and upcoming events that may be of interest to people. I think it's a fantastic way to learn from others and to maybe show work that you're doing yourself as well. Pharmacists are more than welcome to post about initiatives that they may be undertaking or things that they've learned that may be of value to other pharmacists. I think possibly sometimes for me the most convenient thing is that the message from the forum does arrive by email to my inbox. So if I'm there in the middle of the day and there's a new guideline or a new update, I've gotten an alert about it. And I guess the next step from there, and it's an action for me as well, is when I see it, to acknowledge that I've actually gotten this new useful nugget of information or where it would apply in my day-to-day practice. So I think the evening, if I could encourage any new members or existing members, don't be shy about posting. It doesn't have to set the world alight either. It can be as simple as, thanks, that's really interesting for my practice, or ask for more detail if you're interested in work that somebody's posting or highlighting. As I said, highlight your own work and initiatives so other people can learn from you. It's really important that we use the opportunity to learn from each other. And I think,
Ailbhe, and I think that's something that we're hearing from our colleagues at various events across the country, is the beauty of it landing in your inbox. Getting that nugget of information that you can take that'll hopefully impact your day-to-day practice. And again, that's coming through in feedback in our events as well, that our educational events, that that this network is influencing and impacting positively people's day-to-day practice in delivering antimicrobial stewardship. So that's really important.
Yeah, absolutely. We've seen, I know with surveys you've seen yourself, that the members that have completed the surveys have reported an increase in confidence in working within this area. So it's great to see it working. And a group of like-minded pharmacists that are interested in supporting each other.
Yeah. Great. I don't know, does anybody else want to come in on the discussion from the panel?
Sorry, I just have a question. So obviously I work in the hospital sector. I'm Anne-Marie from Connolly. A query I had is obviously in community and within AMRIC, you're doing a lot of work on the common condition service. And in hospital, I'm not really sure what that entails. And I'm just wondering how you're factoring in the AMS considerations in your planning for the rollout of the scheme.
Anne-Marie, thank you, and that's a really topical question, I think. And I think as the months go on, we're going to hear more about the rollout of the Common Condition Service. But again, to reassure everybody on the call, that we've had significant antimicrobial stewardship input into this service. So currently there's 8 common conditions being considered, and 7 of the 8 conditions could potentially result in a patient getting an antimicrobial. So AMRIC has been on the clinical subgroup that has developed all of those protocols. So we've had antimicrobial stewardship to the fore. So it's been really great to be part of that group to ensure that's been taken into account. And again, we've linked with the colleagues that are preparing the education to ensure that antimicrobial stewardship is considered at that point, and also in terms of the monitoring and the communications around the service as well. So thank you for raising that, and it's a great opportunity to share this with colleagues on the call that may not be aware of that. So thank you, Anne-Marie.
Thank you.
And I'm watching our time now, because we've quite a number of items that we want to get through over the course of the night. So without further ado, I'm going to hand over to Anne-Marie and Ellen to deliver to you a piece regarding intravenous to oral switch for antimicrobials. Thank you.
Hi everyone, so my name's Ellen and I work with Mary and Mala on the National AMRIC team. And I'm going to just introduce this section, I suppose. So the second topic on our agenda tonight is intravenous to oral switch. And so simply put, intravenous to oral switch of antimicrobials refers to transferring a patient from IV antibiotics to an oral equivalent when that's clinically appropriate. And as soon as it is clinically appropriate, I suppose. And it's a really key antimicrobial stewardship intervention. So to make sure everyone's still awake, we have a quick poll that's going to pop up on your screen now in a few seconds to see if you have a good understanding of why this is so important. And while you're answering the poll, I'm going to give you a bit of context about why it's also relevant for all of us here tonight in this virtual room. So, of course, it's relevant for specialised antimicrobial pharmacists in the hospital setting. They lead out on this intravenous to oral switch initiatives and this work within their settings. And other hospital pharmacists are also having lots of impact here. We know antimicrobials are prescribed across all wards and all specialties. So there's lots of opportunities to promote and support this work for other hospital pharmacists. This work's also becoming increasingly relevant to pharmacists in the community setting as models of integrated care evolve. And for instance, we see more outpatient parenteral antimicrobial therapy. And community pharmacists too may also find themselves counselling patients on hospital discharge who've been switched to oral therapy just prior to their discharge. So for certain, we know pharmacists are playing a key role in this work. And I wonder, could we pop the poll results? There we are. So great to see widespread awareness and knowledge of the benefits of oral prescribing among the attendees at our webinar tonight. So all of the answers are correct. And to summarize, I suppose oral prescribing should be used where possible, and it's really important and beneficial for patients, for the healthcare system, and also for the environment. So the key benefits are outlined in yellow at the bottom here. So firstly, and really importantly, oral switch reduces the risk of infection from intravenous catheters. And it also reduces the risk of bloodstream and catheter-related infection. So it's associated with higher service user satisfaction as well, higher comfort and mobility for our patients. It reduces nursing time spent in preparing and administering intravenous doses. It reduces the length of stay of patients in our hospitals. And it's also important for the environment. Oral therapy reduces the use of single-use plastics. So, for instance, if you think of all the syringes, infusion bags and giving sets that are required for intravenous therapy. And it decreases the total cost of therapy as well. So the benefits of oral therapy are really very clear, and oral should be prioritized for patients over intravenous prescribing where that is possible. So that kind of makes us wonder then how many patients are on intravenous antimicrobials in Ireland, and is there room for improvement in this, I suppose? And we have some nice data from the National Antimicrobial Point Prevalence Survey, which took place in the acute hospitals in 2024. And on the day of the 2024 Point Prevalence Survey, about 2/3 of antimicrobials were intravenous. And 17% of those IV antimicrobials were suitable for oral switch. So on the day of the PPS, when we look at patient numbers, around 500 patients who were on IV antimicrobials were considered suitable for oral switch. And that's just on one day, and across the participating 43 hospitals that were included in that survey. So how do we go about tackling this? Well, our colleague Mary Kelly, who is HSE AMRIC Chief 2 Antimicrobial Pharmacist, has led out on the development of a suite of resources for intravenous to oral switch. And those were published in February 2025. And those national resources are available on the hospital-related page on antibioticprescribing.ie. And if you want to take a quick look at the poster here, we talked a little bit about how oral prescribing produces less waste. And the poster just really provides, I think, a very nice visual of this. You can see very clearly the difference between the huge amount of waste and single-use plastics associated with just one day of IV metronidazole use compared to how little is associated with oral therapy. From the national perspective, we've also coordinated a national targeted point prevalence survey this year, and one arm of that specifically focuses on route of administration and really aims to support and drive local quality improvement in relation to intravenous to oral switch. But all this work, this national work, is really only part of the picture, because there's a big behavioural piece, a behavioural shift that needs to happen on the ground. And antimicrobial pharmacists and antimicrobial stewardship teams in the acute hospitals are really key to this. So they're key to promote and empower intravenous to oral switch within their settings, and also to adapt and tailor approaches to the local factors. So that's why it's great, and we're really delighted to have on the webinar tonight AnnMarie Garvin, who's antimicrobial pharmacist in Connolly Hospital, Blanchardstown, to give us a bit of an insight into the challenges and learnings from her experience working on the ground as an antimicrobial pharmacist. So AnnMarie, sorry, over to you now. If you want to, I'll push the slides for you.
Okay, thanks, Ellen. That was an excellent summary of the benefits. So when I was looking at my hospital last year, we do these quarterly audits of IV to PO switches, and our target is that less than 10% of patients should be eligible for a PO switch when we audit them, and we just weren't achieving this target. So I knew I had to do some improvement work. So the challenge then became, who should I target when I'm trying to improve this rate of switching from IV to PO? So doctors are obviously somebody we target a lot for our stewardship interventions. They're the prescribers and they review the patients daily. So they're an obvious target. And the additional benefit in this case is that it would reduce their patients' length of stay. So they're incentivized to make the IV to PO switch. The issue with targeting doctors is the constant NCD and CHD changeover. So sustainability is an issue. You have to continually educate. So if you do a quality improvement, you have to keep it continuous. It's not a once-off if you're targeting doctors. The other cohort, I thought in this case, nurses would be excellent because they know their patients well, they know their clinical status, and a major advantage for nurses is that it frees up so much of their nursing time, especially the likes of benzyl penicillin, you know, ones that are given quite often, quite frequently, and take a lot of time to reconstitute. But an anticipated con I had with that was it can be difficult in our hospital. Our wards aren't cohorted, so it can be difficult to contact doctors. And then with pharmacists, so pharmacists are always and useful people to target for with AMS interventions because they often know who's on an IV antimicrobials, and we always want to reduce unnecessary use of IVs. And the added benefit of reducing costs, you know, from the drug budget. The issue then, as a pharmacist, I knew the issues with the pharmacy targeting it more than the other cohort. So there's some uncertainty with pharmacists about assessing the patient's clinical status or knowing the status, especially if documentation in the chart isn't 100%. And then it can be difficult for us to contact doctors if the wards aren't cohorted. And then we have gaps in clinical cover. So pharmacy teams are often short-staffed and you mightn't cover all the clinical areas in the hospital. So after assessing all this, I decided actually I would target all the healthcare professionals that I had looked at and compare them and use a ward as a control to see who performed better. Sorry, Ellen, if you change the slide, thanks. So actually, after doing the work, so I'd done pre-audits, education, and post-audits, I found that the doctors performed the best. So the reason they performed the best is that the prescribers who review patients daily. But after education, the doctors were highly engaged with switching from IV to PO. So the education was really successful. And during the education session, we talked about how they could best target this. So they have issues getting cardexes when drug charts when the wards aren't cohorted. So it can be very hard for them to actually get the drug chart to see what the patient's on and make that switch from IV to PO. So they said they were going to prioritize obtaining that drug chart and having a look. And also for cases where they mightn't be able to, they were going to add a tracking. So just a column on their patient list where they write what agent the patient's on, what route it is, and what duration it is, so they can continually keep on top of that. And that really helped. So they had a great improvement, and we reached target on the first audit post-education. Now, unfortunately, the other two arms that I was really hoping to be successful weren't as good as the respiratory doctors. So the nurses, although they know the patient's clinical status, it was my own, I hadn't realized that the nurses don't routinely check the patient's bloods. And so if you're not checking the bloods, you can't assess for an improvement in inflammatory markers. And so you can't recommend the IV to PO switch. So that was my own lack of knowledge that had led me. And then the other issues were they had difficulty contacting medical teams. So even if they did check the bloods, if they had the time to check the bloods and did so, it would take time to contact the medical team, and actually it would take so much time that they wouldn't feel the time saving for themselves on their shift, and the time saving would be for the next nurse on the other shift. So they weren't as incentivized as I thought they would be. And then with pharmacists, what I kind of had anticipated was competing priorities. So medicines reconciliation is taking a lot of time for hospital pharmacists, and on the day of one of the audits, the pharmacist had 9 medicines reconciliations to get through. So there's lots of competing work, and there's gaps in clinical cover. So one of the audits was done when the pharmacist was on annual leave, just because that's the way the hospital works. So there's no cross cover because of staffing resources. So if the pharmacist isn't there, the work isn't done. And then difficulty contacting medical teams. It's an ongoing hospital pharmacist life. It can be hard to reach the teams with your intervention. And so then after finding that the respiratory team would perform the best, I wanted to see, so they were medical doctors and they were highly engaged, could I apply this to surgeons? So what I did with the surgeons as well as pre-audit, post-audit and education, I wanted to tailor that education to the surgeons. So I did a survey before education just to find out their attitudes, perceptions and knowledge to switching from IV to PO. And I got 28 responses in total, which is a poor response rate considering the number of surgeons we have in the hospital. But what I did think was there was probably self-selection bias. So people who don't look at IVs didn't want to complete the survey. But for those that did complete the survey, 86% of them were aware of our local IV to PO policy, which was very positive. Half of respondents reviewed the drug chart daily, which is something we want to improve, not just for antimicrobials, but for all drugs. And 79% of respondents first assess the suitability when source control is achieved, rather than at 48 to 72 hours as per our policy. And this is because the surgeons strongly believe that the IV is not as effective as PO and that source control is required. And then 33% of respondents reassess daily in line with our local policy. So we want that to be higher as well. So when I delivered the education, I was trying to address these issues the survey raised. And actually I found on post-audit that the tailored education did improve switching from IV to PO. But again, there was an issue with sustainability. So the effect was quite strong at the first audit post-education, but it does die down over time. And the other issue was educational opportunities. So not all the surgical teams had a forum for me to provide education within the hospital. So I could only target 2 main teams. So we still have a lot of work like that has shown that you can improve with education, but we still have a lot of work for the future things to work on. So we did participate in the AMRIC PPS and we've submitted our results to AMRIC, and I also had a look at them. And we're still around 18%. So we're not achieving our targets. So myself, in conjunction with my colleagues on my team, will meet and we'll discuss, and I'm hoping to get more stakeholders involved. I've just discussed this with colleagues, like the best way to get change when you're looking at the results of something. And I think if we include the clinical directors and the assistant clinical directors and they drive that change downwards themselves, we might have more success in driving and sustaining change. So we'll move on to questions, if anybody's questions for Ellen and I.
Anne-Marie, thank you. And I have one comment. This is a really insightful data, and I think the roles that the various professions take on in regards to intravenous to intravenous to oral switch. And I would like to call out that I think the enhanced role that the specialist pharmacist could have if they had prescribing capabilities in terms of allowing that IV to oral switch happen. And I suppose as we are moving into the prescribing space in the pharmacy profession, it'd be fantastic to see if our specialist pharmacists would be considered maybe as the next cohort to look at that and consider it. So yeah, is there anybody else that wants to come in on that discussion? And our colleague Aisling O'Leary has contributed to the chat the sustainability piece, and Aisling is very active in this area and has contributed to some of the key HSE documents in this regard. So Aisling, great to have you on the call, and thank you for your contribution. Anybody?
I have a question actually for Anne-Marie, but first of all, just thank you so much for the presentation, Anne-Marie. You're so good to come on and do that. I think it really gave us a really rich insight into the kind of challenges and the complexities that exist on the ground, and it's quite nuanced, isn't it? It's like there's so many different healthcare professionals involved, and there's so many organizational factors that can influence the implementation of IV to OS on the ground, you know. So my question, I can't see the chat, but it refers to the sustainability piece, and I'm wondering about, you know, we talked about the extra waste associated with inappropriate IV antimicrobial use, and I'm wondering on the ground, from your perspective, do you think it's a factor, a motivator for people to change their behaviour, this sustainability angle, and that kind of piece?
So going into it, I didn't know whether it would be, but actually delivering the physician education, I found that it really was. I delivered the physician education I think it was last November, and actually I was using a PJ article from 2023 that said IV SIP prophylaxis is 60 times higher carbon footprint than PO. And that really landed at the education, especially with younger NCHDs. So the NCHDs who are interns, SHOs, are normally in their early or mid 20s. So they really were like, oh my God, this is something I need to look at, because they're just more invested in their own carbon footprints than I was when I was, you know, in my early 20s. And it really did land, and it was useful. And actually I saw that later that year there was an IRP Sustainability in Pharmacy webinar, and also you sent through PAMSnet, which I found, just out of curiosity, very useful, the Medicines Formulary Guide to the Carbon Footprint. So if I was to deliver the education again, I'll obviously look at that and have more examples for them rather than the one that I picked from the PJ, because it is something that really does seem to land with them.
Yeah, that's great to know that kind of message does resonate, and it's possibly something that others on the call might be able to replicate in their setting if you found it so useful. Thanks, Anne-Marie.
Great. Thank you, Ellen and Anne-Marie. Some really great insights and again, sharing and signposting of resources that are available to you in your day-to-day practice. In the interest of time, I'm going to move on to our next section of the webinar, and that's to hand over to Mala Shah and Dr. Scott Walkin with regards their work on respiratory tract infections in primary care. Thank you.
Thanks very much, Mary, and thanks everyone for joining today. So, as Mary mentioned in her introduction, we have a lot of work to do in terms of reducing the total amount of antibiotics that are consumed, and the EU has set those targets for 27% reduction. So we have made very minimal progress in this area, so we have a long way to go. And we know that 90% of antibiotics are used in Ireland, are used in community settings, and that 90% of antibiotics are used in community settings. So it's not all bad news, because in terms of those the kind of the green agents, we're doing really well with an increase in proportion of those green or access antibiotics, and so we're exceeding the targets set by the EU already in that regard. And so the Green Red Initiative has had has been very successful. Next slide, please. So in terms of where can we make a difference? So respiratory tract infections are really the most common presentations in primary care, and we know that there are high levels of antibiotic prescriptions for self-limiting and viral infections. In fact, some studies have shown that up to 30% of antibiotic prescribing in primary care may be unnecessary. So there is considerable scope to reduce antibiotic prescribing for respiratory tract infections. So last year, the Department of Health published a paper. It was a systematic review and a meta-analysis entitled Changing Behaviour and Reducing Unnecessary Antibiotic Prescribing. And that paper indicates that behaviour change interventions have potential to reduce antibiotic prescribing by 21%. So changing behaviours are looking at patients' antibiotic-seeking behaviour and GP behaviour on antibiotic prescribing for self-limiting respiratory tract infections in this case. So some interventions that have been shown to reduce unnecessary antibiotic prescribing include education. That's education of the prescriber and patient on prudent and appropriate antibiotic use. And the other ones we're going to target in today on what the work we've done to address this is communication training interventions, which are aimed to improve the practitioner's ability to collect information on the patient's concerns and expectations, exchanging information on symptoms, advising natural disease course of treatment, agreement of and agreeing a management plan, and providing guidance about when to reconsult. And the last kind of key thing that we'll focus on today is that delayed prescribing, which is really the practice of a GP providing a prescription with structured advice to avoid filling the prescription for a number of days first to see if the symptoms will resolve independently of antibiotic use. So we won't be covering the point of care testing and decision support tools and audit and feedback today, which are some other interventions that have been shown to reduce unnecessary antibiotic prescribing. With this, I really swiftly want to hand you over to Dr. Scott Walkin, who is the ICGP lead for IPC and AMR, and he's an assistant scheme director for GP training also. So he is going to discuss how the application of communication skills model and the interactive use of a Treat Your Respiratory leaflet can support GPs in consultations for self-limiting respiratory tract infections. Thank you, Scott. I'll hand over to you.
Thank you very much, Mala, and thanks very much to the Institute for the invitation this evening. It's really wonderful to have the opportunity to speak to such a wonderful group. I really feel that when a phone call comes in to me from a pharmacist, it usually means it's going to save me some catastrophic error. So I love to hear the pharmacist calling, I have to say. So thanks for the invitation. Next slide, please. So the previous slide just described and Mala described my sources of income, and I have no conflicts of interest to declare. Next slide, please. So I think everybody on this call is likely to be aware that sometimes when somebody is sitting in front of a prescriber or a GP, and the GP knows or highly suspects that the cause of their symptoms is a viral illness, despite that, sometimes that person will end up leaving the room with the prescription for an antibiotic. So what that means really is that, and that happens for a variety of reasons. It might be diagnostic uncertainty. It might be patient pressure or perceived patient pressure. I think doctors sometimes overvalue patient preference for antibiotics. There's some evidence to support that. It may be, a wet Friday evening in January syndrome, where the prescriber knows that if they prescribe, that it will get them out of the building a little bit quicker. Having said that, in the longer term, that's counterproductive. So there are various non-medical drivers. So I think we need to move beyond knowledge and move towards behavioral and communication skills training to support prescribers in avoiding unnecessary antibiotics. And that brings me to the CHEST SSS acronym. So this is an acronym which describes a consultation model that we're rolling out. It's now from this semester part of all the medical schools in the country are introducing it. It's mandatory training for GP trainees nationally, and it is also available for GPs through the Irish College of GPs. I'll come to what it stands for in just a moment. Next, please. And part of the CHEST SSS model is supported by the Treat Your Infection leaflet. So I'll show you that as well in a moment. So next slide, please. So you can see there the red text vertically on the left-hand side describe the acronym there. So concerns, what that means is if somebody's coming into me and they want let's say they want a sick note or something like that, I'll need to manage that in a particular way. But if they come into me with respiratory symptoms and they think they have a very severe pneumonia and they're worried that they might have to go to hospital or worse, well, that needs to be managed differently. So it's important to identify the person's concerns. The next section, the history and examination. So that's a standard part of any assessment. But in particular, if the reassuring findings in the history and the examination are commented on as the examination is progressing, that's very reassuring for people. So it might mean something like, well, your heart rate is fine and there's no temperature, and when I listen to your chest, it's okay. So that's all good news. It might be something like that, okay? The next section there is expectations. So that's to find out specifically if the person is interested in taking an antibiotic. So, what do you think about an antibiotic today? Might be a question, something like that. Symptoms is one that I don't deploy all that often. What it means is if somebody's worried about a particular symptom, that you can explain, well, you know what, that's actually not that severe a symptom, assuming it's not a severe symptom. So it might be, oh, the sputum is green, so I need an antibiotic, doctor. And I'll say, well, the green sputum is the norm actually with infection, even with viruses. So it doesn't necessarily mean an antibiotic is needed. So that's what symptoms means. And then timelines. It's remarkable how we underestimate the duration of symptoms for lots of common conditions, and I'll come back to that in a moment. The shortcomings of antibiotics. So I think highlighting the downsides and the risks. So, vomiting, diarrhea, thrush allergy, superbugs is the delightful menu that I often present. And then self-care means giving people advice about what they can get from the pharmacy that will, and also non-medication options that will help them to manage their symptoms. And that promotes self-efficacy, which means that they will hopefully learn that the symptoms that they have, they can manage without necessarily needing a medical consultation. So in the longer term, antimicrobial stewardship also reduces it increases medical workload capacity. And then finally, safety netting, because of course, a small percentage of people, unfortunately, will have progression to very severe illness. So if you look at the vertical text on the left-hand side, you can see that the first 5 minutes of the consultations covers the CHES, and then the TSSS is covered by the patient information leaflet, which I think we're going to move on to now, hopefully. If the next slide. Yeah, okay. It's not quite, oh, there we are. Okay. Hopefully that's visible to people. So you can see the panel on the left. Thanks, Mary. You can see the panel on the left-hand side. So, you know, it can be surprising for people that cough symptoms often take up to 3 weeks to settle down. And sometimes I feel if I say that, they may not necessarily always believe me, because we all, when we're sick, we want to be better faster. But if it's written down on a piece of paper with HSE endorsement on it, I think it adds, and the RESIST endorsement, it adds credibility. So this is, I use this every time somebody comes into me with respiratory symptoms, and that's one of my main motivators for doing so. The next section, the bottom left, gives self-care advice. And there's also a link there with the QR code to the common conditions section of the HSE website to help people look after their own illness. I will often write in things like maybe paracetamol syrup doses or ibuprofen doses in the bottom left, and maybe other interventions that I would suggest, whether, I don't know, Diflam or something like that for a sore throat. The top of the right-hand side covers that shortcomings part of the risks with antibiotics. And the next section, if your condition does not improve, you might just be able to see there's a line there where if somebody is using a deferred or a delayed antibiotic or a backup antibiotic, that the prescriber can write in there when they propose or when they suggest that the antibiotic should be used in the absence of an improvement. And the rest of the leaflet relates to safety netting. So some of the signs and symptoms of severe illness and when people should return for a review or indeed to the emergency department. Extremely rare, but of course, very important when it does happen. So I think that's all I was going to say. Can I just see the next slide? That's it,
Yeah.
I think. That's it for me, yeah. So very happy to take any questions through the chair if there are any. Thank you very much.
Thank you so much, Scott. So Scott has been such a great advocate for promoting this communication skills training and the leaflet and the use of the leaflet with his GP colleagues. And it's great to see that it's reaching the undergraduate level as well, because this is such key interventions in terms of behavior change, which are needed at this stage to reduce the unnecessary antibiotic prescribing. So this Treat Your Respiratory Tract Infection leaflet, you can see there's a QR code there, so that's to access it yourself. It's on the website antibioticprescribing.ie under the respiratory infection sections, so you'll find it there also if you want to look at it yourself. So we published it last year, and it's actually one of the most downloaded resources on the website. So up till August 2025, it has been downloaded over 8,000 times. And the good news is that GPs will actually have printed copies in the next month or so. So AMRIC will be posting out printed copies to the GPs. So it's quite likely that the patients will be coming into pharmacies with a copy of this leaflet. So at least you'll know a bit of the background about it and how how GPs are using it. So I think the next slide then is a poll, is it? So yes, so just reflecting on the leaflet, the next poll is, would a similar RTI leaflet be useful for community pharmacies to assist antimicrobial stewardship? And I suppose in the chat, it would be lovely to also, if anyone has any other thoughts and ideas about other things that can be done to support community pharmacists in this messaging around respiratory infections and self-limiting viral infections, please do put in your suggestions there. Okay, that's great. So it seems that it would be there's 91. Yeah, it's a good support for a similar leaflet for community pharmacy. So that's really useful for us to know when we're planning our next stages, our next steps, to support pharmacists in trying to reduce unnecessary antibiotic use and educate patients and empower patients to manage infections themselves and when to look for help. Thank you.
Okay, thank you, Mala and Scott. I think that was a really informative presentation, and I really look forward to seeing the impact of this initiative, because I think it has massive scope, and it's fantastic that it's been downloaded so many times in such a short space of time. I think that is a clear indication that the value GPs have in using this tool in their consultations. So that's really positive. I see we have a question has come in here. Do we have any idea what percentage of patients don't use the delayed antibiotic prescription? So
Mary,
I don't think we have that data. Scott, you would like to come in?
I can come in on that. And Gillian, thank you very much for the question. So I'm a simple country West of Ireland fella, so I like headline numbers and approximate numbers that are easy to remember. So the answer to this, it really depends on the indication for the antibiotic. So with urinary infections, cystitis, the vast majority, nearly all of deferred antibiotics end up being dispensed. So that's for UTIs. For respiratory symptoms, estimates vary, but in broad terms, and an easy to remember number is that roughly half of deferred antibiotics and prescriptions end up being dispensed. Thank you.
Thank you, Scott. I suppose this would actually make a lovely study, which may, with electronic health records, etc., that would be easier to do. But I suppose in Ireland we don't have any specific figures of filling of delayed antibiotic prescriptions yet. But if anyone would like to do this kind of a study, that would be welcome. Yeah.
And I see Marius has added some very helpful context there. And these insights, again, are really important for us to be aware of. So the delayed prescription is often dispensed on the day that it was written. And as I mentioned earlier on in our submission for INAP 3, delayed prescriptions, and again, whether that is going to be the correct term that we use for them going forward, there's a huge piece of work to be done in this regard, and it'll be very much a collaborative piece amongst pharmacists and our GP colleagues.
Scott, I have one question for you. You talk about this chest SSS model, but using it in practice, does it actually take much time? Does it take much extra time and using the leaflet in your consultation?
It doesn't. I mean, I use it every day, so I'm very used to it. I'm very familiar with it, and I use it interactively. So I will. It's not a parting gift as the person is walking out the door. I'll sit down with the person, write down, well, look, this is the ibuprofen syrup dosage I would suggest that you take, etc. It doesn't really. I mean, I'd be doing it anyway, and I think with the leaflet, I end up doing, particularly the safety netting. I end up doing the safety netting better with the leaflet than I would without the leaflet. So I think in the heat of battle, in a clinical consultation, it is time neutral. It doesn't make much difference one way or the other, but in the longer term, I think because it self-empowers people to look after self-limiting illness, I think it's really likely that it reduces future presentations for self-limiting illness. So I think in the long term, it's likely to be time-saving. In the short term, it doesn't lengthen the consultation, in my experience.
Thanks, Scott. What you've been saying is very much reflected. I conducted a feasibility study on the use of the leaflet and got GP and patient feedback, and they all found it really valuable, very feasible to use, didn't increase consultation time, but really, really framed their consultation and empowered the patients to self-manage infections, and patients felt it reduced their kind of antibiotic seeking behavior, which is a really useful finding. And for some GPs, they felt that it helped them prescribe less antibiotics as well. Thank you.
Great findings. Anybody else want to come in from the panel on the discussion?
Well, I wanted to ask one question. Obviously, Scott, I mean, really interesting to see it. And I suppose community pharmacy is my background before joining the IOP. And I'm probably just a little bit interested to find out a little bit more about maybe what the conversation looks like on your side around a delayed prescription and what pharmacists could learn from that, to bring to their consultation. So I suppose we've seen the pharmacists in the chat saying that they're seeing it come in with delayed on it, and it can be difficult then to I suppose have that conversation, but in terms of learning from you so that conversations are aligned.
Yeah, thank you. Honestly, I very, very rarely use delayed antibiotics. That's just my practice. I very rarely use them. I used to use them a little bit more, and I think over the decades, I became more confident in telling people that I just didn't think they needed antibiotics, hopefully in a way that doesn't cause offense, So it's always a slightly tricky one, because what you're saying on the one hand is you don't need an antibiotic. And then on the other hand, you're saying, but here's a prescription for an antibiotic to use in whatever circumstances. So that's where it's just a little bit tricky. And I have to say, I think you're right that there is because of that issue. I think you're right. It is a tricky conversation. What I would, when I do, I find myself using them when I'm put under a lot of pressure, and despite my deploying chest SSS and using the TYI leaflet, that I'm getting this blank stare back and going, so are you going to give me the antibiotic? They're the circumstances where I use it. And I'll usually say, look, I really don't think you need an antibiotic, but if you want an antibiotic, I will give it to you. And here's the prescription. I think what you should do is avoid it, but maybe just give it 3 or 4 days, see how you get on. I'll give some advice about symptomatic management, and hopefully they won't be running down as quickly as they can to the nearest pharmacy to cash it in. So that's what I do. Thank you.
I suppose as we touched on briefly, the idea of delayed is maybe antibiotic for if you are a little bit worse, rather than just wait a few days. The purpose behind it is if you haven't improved.
Yeah, well, I mean, usually for me, it's in my head, I'm thinking an antibiotic is not going to help here. So I try and set the bar pretty high. But to be honest with you, I think the circumstances in which I use them, I actually think it's likely that the proportion of those that are obtained or dispensed is probably higher than what the literature would say. Admittedly, we've no literature in Ireland, but the literature internationally.
Thanks, Scott.
Thank you. I think really helpful discussion, and I think our colleagues that are joining us tonight are certainly gaining great insights for their day-to-day practice, considering the messages coming in on the chat in regards to delayed prescriptions. And I think it really highlights that we need to do work in this regard. I'm going to move us on. Really thank you for the great discussion, and I think there's possibly lots more discussion that people on the call would be grateful, but I'm also mindful of keeping us to time and keeping all of our panel available to go to their other jobs after the session. So I'm going to take us towards the closing of the session, and what I really want to ask all of you is to consider what action you could take away, and we're only asking for you to take something simple if that's the case in terms of your time commitment, but to choose something in the antimicrobial stewardship space that will help you deliver on antimicrobial stewardship in your day-to-day practice. It could be our antimicrobial stewardship micro-learning that's been developed for community pharmacists. It could be accessing the website either from a community or a hospital perspective and accessing various resources that will help you in your day-to-day practice. If you aren't a member of PAMSnet, I hope we have convinced you the value of that network tonight and what you can gain from that in your day-to-day practice. So please do join us and become a member. And there's also an IIOP e-learning module on antimicrobial stewardship on the IIOP website that you could avail of. Next slide, please, Ellen. And finally, in regards to call for action, I just want to highlight that if somebody on the call has the idea that they feel they could do better in that regard for a specific project and get some funding, there's a HSE Spark Innovation Programme. And that really is to provide funding for innovative projects, can be up to quite significant sums. So if you think you've got a really good idea, there's various supports. We've included the details here, so maybe that could be your antimicrobial stewardship action. So I suggest you look into this further and you can access those resources there. And we'll move along. And so again, getting you to commit, possibly a behavioural intervention included here by getting you to vote as to whether you're going to identify an action in your setting to help promote the better use of antibiotics. Okay, so we await with interest what the result of that poll is. And when we get the results of that, what we will move on to are just to go through quickly some of the questions that came in. Great, okay, fantastic. 97% of you have chosen an action that you're going to carry forward. So that is fantastic. And thank you all for your work in keeping antibiotics working for all of us and for all of our patients. So in terms of the questions that came in on webinar registration, are there any forums where doctors and pharmacists could liaise re antimicrobial stewardship? So I think we're definitely moving towards this space. This PAMSnet community of practice platform that I'd said to you is open for pharmacists only. But I think definitely, and we're hearing from our colleagues in the third level institutes on the various healthcare professional education programs, that they are moving to interprofessional learning. And I think having Scott here tonight is an example how we're doing this with the PAMSnet. So I think this is something that hopefully we will see more of and participate more of. And certainly from AMRIC's perspective, when we're sharing various communications, we always make sure that what we have shared with the GPs that we also share with our community pharmacists, so that that all colleagues are aware of the various pieces of information. Any changes around antibiotic prescribing in managing sepsis? And I'm actually going to take this question as well. So there was a recent update to the sepsis guidelines in Ireland, and the sepsis programme hosted a webinar, and I'm sure if you search for that, it's available. But what they have done is they have changed their guidelines in terms of the management of patients with possible sepsis. So where for those patients that have definite sepsis, the antibiotic should be given within an hour window. But in this possible sepsis, it allows for a 3-hour window for the administration of the antibiotic. And that gives the clinician time to consider alternative diagnosis. So maybe by the time that 3-hour window is up, it may be that the patient actually has an alternative diagnosis and it's not sepsis. So again, I think this is a really important antimicrobial stewardship aspect that has been taken into account in the sepsis programme. Our next question is, I don't know how to word this, but why is the dose of some antibiotics, specifically amoxicillin, the same for a 5-year-old or a 50-year-old? So Mala, I might ask you to come in on that question, please.
Sure. So I think historically there was kind of a relatively arbitrary principle of halving an adult dose for penicillin in older children and the younger children. And that was from the 1960s, and it wasn't questioned for many years. And then really it was probably more in the about 2011 onwards that place like the BNF for children, they changed their age banding doses to come in line with the European recommendations, because there was widespread concerns for underdosing in children. So when in children you need a higher mg per kg dose compared to adults to achieve similar blood concentrations and therapeutic effects, because amoxicillin is excreted mostly unchanged in the kidneys. Children's kidneys filter blood more efficiently, so there's a quicker elimination of medicines in the bloodstream. And also children have a different body composition, higher water content and lower fat percentage. So this affects drug distribution, and this would mean that really you'd need that higher dose in children. Otherwise, you'd get subtherapeutic amoxicillin levels that would potentially lead to treatment failure. So that's the reasoning behind the dose parity, the dose disparity there.
Thank you, Mala. That's really helpful. The next question is in regard to dental. And actually, Mala, I'm going to ask you to take this question as well, if that's okay.
Yeah, I'm not quite sure I understand this question, because really for dental extraction, antibiotic prophylaxis is not generally recommended unless the patient has a previous cardiac condition. So what I'm going to do is I'm going to post in the chat the section of the guidelines on antibioticprescribing.ie that deal with endocarditis, with dental prophylaxis, and that might help maybe people to go through the guidance to see exactly when and if the prophylaxis is needed, is recommended, and usually it's a single dose for endocarditis prophylaxis. Thank you.
Great, Mala. Thank you. And the final question is around fluoroquinolones and the adverse effects associated with those. And Ellen, I'm going to hand over to you to deal with this, please.
Yeah, thanks, Mary. That's a great question, and it's good to see such a high awareness of the kind of adverse effects associated with fluoroquinones in particular. Now we know that fluoroquinones are red antibiotics, and I suppose they should be avoided first line, but they're also associated with those very severe adverse effects such as tendinitis and tendon rupture that I mentioned here. And I suppose I should really be thanking the person who popped this question in, because it gives us an opportunity to shamelessly plug one of our own resources. So we do have one of our 5 antimicrobial stewardship micro-learning videos for community pharmacists focused specifically on fluoroquinolones, and it goes through some of the points for counselling patients and some of the AMS actions that you might take if you received a fluoroquinolone prescription in your practice. So I'll pop the link to that into the chat. And another resource that might be useful in answering this particular question is if on antibioticprescribing.ie, if you go to the safe prescribing tab, there's a full page on fluoroquinolone cautions and warnings associated with fluoroquinolones that I think will help. So I'll pop those 2 links into the chat now.
Thank you, Ellen. And I really want to, so we'll take chance now to close out the session. I see that so many of you have stayed on for the answering of those questions. So we really thank you for your commitment tonight, for joining us on the webinar, and for staying to the end. So we hope that it's been useful. And yeah, thank you everyone, and thank you to our hosts, the IAOP.
So now we just have a couple of slides just to finish out. So firstly, I'd like to thank everybody from the panel for what was an absolutely fantastic discussion this evening. I was really looking forward to this evening's webinar, and I was not disappointed. It was really, really good. So to remind people to please complete the feedback survey, and the link is in the chat at the moment, or it will be emailed to you. I think we have absolutely a wealth of material to start a CPD cycle, especially as we've been prompted by Mari with the call to action. So just to remember to think about starting a CPD cycle with the knowledge that you gained this evening. And all that remains for me now to do is to let you know about the next IIOP webinar, which is going to take place on Wednesday, the 5th of November. And it's Menopause and HRT Medicines with Dr. Deirdre Lundy. So thank you very much. Thank you for your attention. Thank you for your questions and your participation. And thanks very much to the panel. Good night. Thank you.